Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds. Premier education brought to you at no cost thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. This week, I'm very excited to present to you Dr. Puneeth Iyengar. Many of you all will already know his work in the setting of oligometastatic disease. He's currently the Director of Metastatic Services at the Memorial Sloan Kettering and coming live to us from America. Puneeth, over to you.
Professor Lim, it's a very much of an honor to be presenting the grand rounds today in thoracic surgery at the Royal Brompton. I hope to do the audience justice today, and my talk is really the idea of continuing to refine radical local therapy utilization in the setting of advanced disease. And in this case, the focus will be on advanced non-small cell lung cancer. These are my disclosures, none of which are relevant to today's presentation. So I'd like to start off by providing this timeline of advances in radical treatment of oligometastatic disease. And I cannot say more than simply stating that surgeons have taken a very significant role in our understanding and utilization of local therapies in the management of oligometastatic disease. And this dates back decades. And so major props to surgeons for their ability to start thinking about outside of the box of how to manage metastatic disease in the setting of sarcomas and colorectal cancers, for instance. And then we, of course, had Hellman and Wexelbaum, who provided an intellectual push for us to start to understand how to optimize local therapy and to see if it is beneficial in the advanced setting. But I would say that there were 2 or 3 other major contributors to the evolution of radical treatment for oligometastatic disease. 1, an improvement in systemic therapy, an absolute must. And 2, an improvement in the evolution of local therapy utilization in terms of both surgical management as well as SBRT. So, and then the final is, of course, improved imaging to understand and identify microscopic disease earlier in its disease state. So all of these contributed to our understanding and utilization of local therapy. And so I'm going to focus on 2 areas, consolidation and quickly oligoprogression, before we talk about the future. So in terms of oligoprogression, in terms of consolidation, there were basically 3 or more than 3 fundamental studies that established in a randomized fashion, small randomized phase 2 studies, that local consolidative therapy in the oligometastatic non-small cell lung cancer space may actually be beneficial not just beyond palliation, but for both PFS and in 2 of the studies, OS. These studies really set the stage for future larger studies. Unfortunately, none of these trials incorporated immunotherapy as the systemic therapy of choice for those patients. And so there was still more we had to learn about the consolidated setting and local therapy in the metastatic setting. So this led to NRG LU002. And LU002 was a study that simply asked the question, if we added local therapy, be it surgery and radiation, in the consolidative setting after 4 cycles of induction systemic therapy established in oligometastatic patients, could the local consolidative therapy improve progression-free survival and overall survival over maintenance systemic therapy alone? And so that is the kind of the gist of the study. We randomized 218 patients in a 2-to-1 randomization favoring local consolidative therapy plus maintenance systemic therapy over maintenance systemic therapy. We had large buy-in. It was an international study. And at 218 patients enrolled, we looked to see what our analyses were at a planned interim evaluation. Taking a step back, what we realized was that this had become a study of immunotherapy minus plus local consolidative therapy, with 90% of patients in both arms receiving immunotherapy-based systemic therapy. A majority of the patients had 2 or fewer sites of disease that needed to be consolidated at the time of enrollment. A majority of the patients had a good performance status. There was always been a question of how many of these patients were oligo-induced versus oligo-persistent. For pragmatism, we allowed both populations, but ultimately a majority, approximately 90% in both arms of the study, were patients that were oligometastatic at diagnosis and continued to be oligometastatic at the time of enrollment after at least 4 cycles of induction systemic therapy. When we looked at what were sites of treatment, a majority of patients had either primary disease and or regional lymph nodes treated with local consolidative therapy. Of course, other patients had other metastatic sites treated as well. So let's take a look at the high-level evidence or findings. When we looked at patients at that interim analysis for PFS after 22 months of follow-up and 29 months for surviving patients, we saw no significant improvement in progression-free survival. At 1 year, the rates for the LCT arm were 51.5% versus 48. At 2 years, it was 40 versus 36%, but not statistically different. And even in that 90% of patients that had immunotherapy-based regimens, we did not see a statistical difference in outcomes, though the hazard ratio was 0.9. Again, with respect to OS, we had a 1-year OS rate of 75% or so for both arms, 2-year OS of about 56% in both arms, not statistically significantly different. And so, you start questioning ourselves and saying, why did we not see the same findings we did with these previous studies, smaller randomized phase 2 studies that clearly showed a PFS and OS difference? So we started digging a little bit deeper. We looked at patterns of failure, and though these patterns of failure were not statistically significant with the confidence intervals crossing 1, there was a hazard ratio of 0.64 favoring the LCT arm and local consolidative therapy arm in terms of time to infield failures. There was also a trend towards a benefit with LCT with respect to time to new lesion development. And these are two of the metrics that we thought local therapy would improve: local control and time to a new distant disease. So the question is, why didn't these benefits translate to an improvement in PFS and OS? So we really started looking at different outputs from the trial. One was that we found clearly, and this is very obvious to any medical oncologist or even surgeon, that that the patients who received less maintenance systemic therapy had a reduced progression-free survival. And this was landmark analysis that was conducted after a 3-month time point. And what we also noticed was that patients who received local consolidative therapy had more toxicity. They had more grade 2 or higher toxicities and more grade 3 or higher pneumonitis. So when we looked at the patients that developed pneumonitis, a majority of which were in the local consolidative therapy arm, what we found was the patients that underwent local therapy, and most specifically to primary tumor plus lymph nodes, had an increased risk of pneumonitis. Those patients with pneumonitis ended up getting less maintenance systemic therapy, and maybe it manifested as a reduction in progression-free survival, as you can see here. So we started thinking that maybe it was the toxicity that limited the ability of the local therapy to complete its benefit from a local control and freedom from distant new failures to an actual PFS and OS benefit. When we looked at multivariate analysis, there were 2 statistically significant factors that portended for a worse overall survival. That was naturally worse performance status, and as many people have always said, disease that meted out to the liver also portended worse overall survival associations. So at grand total, though the study did not lead in the direction that we had hoped or anticipated, there were many things we could take away. And the limitations of this study certainly were, number one, we didn't anticipate the type of toxicity we saw, and that may have been an interface between immunotherapy and radiation that we need to still think about. Number two, we really didn't enrich for patients who would benefit from local therapy beyond a single cross-sectional imaging study conducted at the time of enrollment that determined that the patients had 3 or fewer sites of extracranial metastatic disease. There was no other biomarkers which helped us choose which patients which would most ideally benefit from local therapy. And as you can see from this kind of pictorial, as a radiation oncologist or a surgeon or a medical oncologist, we have no idea of knowing after we offer local therapy for these patients what disease trajectory they're going to go, because we simply do not have the data and the knowledge to predict metastatic trajectories. So all of these, I would argue, are limitations of this study. So how can we learn and move forward in terms of future studies and future enrichment for patients that may actually benefit the most from local therapy. So I think what we need to do is start binning patients based on genomics, based on proteomics, based on clinical characteristics. And what we really need to do is we need to understand the following types of patients: those that have such a poor prognosis on any systemic therapy that no local therapy will benefit, and move those patients to the side for the second. And then think about the patients who have such a good response to systemic therapy, such as those patients with mutations that respond to lorlatinib for 5, 6, 7 years without any progression. Move those patients to the side, because local therapy may not be important for those patients that are doing so well on systemic therapy, and really focusing on the middle patients, where the systemic therapy is just keeping the disease under some form of macroscopic control, keeping it at a microscopic level, and then seeing whether local therapy will actually benefit this patient population the most. Another way of thinking about this is to basically identify, through a combination of biology and in silico computational approaches, which patients represent the early progressors on systemic therapy, which patients are the non-durable responders, meaning those patients who respond for some period of time and then maybe develop acquired resistance and then start failing in different sites. And then which patients represent those durable responders, where the only benefit of local therapy may actually be in the setting of oligoprogression. And so that is what we're trying to do at MSK with our collaborators, is we're trying to annotate true patterns of failure in the absence or presence of local therapy, to better understand metastatic trajectories as a function of time and biology. And then we are trying to use multiple clinical, biologic, and pathologic and imaging correlates to try to associate with those patterns of failure and the timing of failure. Then we can start developing predictive models that are better equipped to measure and predict metastatic trajectories. So this is certainly an important study where, in some ways we've already started combining LU002 data sets as well as MSK data sets to develop a joint data set of patients who are oligometastatic diagnosis, who are polymetastatic diagnosis, who do and do not receive local therapy, to give us this greater insight into these predictive and prognostic models. And it's not just about the efficacy of the treatment. As we saw from the trial, it may also be about being able to predict with an increased certainty which patients are going to develop toxicity such as pneumonitis from the combination of therapies, and how we can basically overcome that limitation. And so our goal will be to predict both efficacy and toxicity in optimizing the therapeutic ratio. And so in terms of just this portion of the talk, I would argue that it's safe to say that local consolidative therapy is certainly not indicated for all patients. I would also argue that based on the data, it's not indicated for most patients at this time. We don't have the data to support it. And this is, NRG LU002 is the largest study ever in the non-small cell lung cancer space, asking the question of local therapy utilization in the oligometastatic setting. But I still think, and I was talking to Professor Lim before the presentation, that multidisciplinary discussions, whether it's a tumor board or multi-D clinics, will be the best scenario, where we have surgeons involved, medical oncologists, and radiation oncologists to say, this patient may have been on immunotherapy for 2 years, and there's still some 1 or 2 sites of smoldering disease. Maybe we can eradicate that area and avoid the likelihood of greater resistance. And so it's still, I think, an option. It just takes a team to come up with that solution, or that for that patient population. The other thing is, we have to account for toxicity and better understand under what scenarios this toxicity manifests. What we found with LU002 is wide swaths of radiation treatment to lymph nodes plus larger primary tumors in a 45 to 15 gray regimen, portended for greater likelihood of developing pneumonitis in the setting of sequential immunotherapy. And maybe our goal in the future is to avoid treating everything, but maybe just treating the primary, or just managing the nodes with systemic therapy. We have to see. But ultimately, biomarkers are needed to really predict metastatic trajectories. And so if you now move ahead to oligoprogression, again, it's a story about lack of predictive prognostic markers. This is an outdated slide, but still I include it because it's so apropos, that we still have no idea how to predict in a very ideal fashion which patients are going to benefit from IO, which patients will not, across multiple different cancers, and especially in non-small cell lung cancer, where really one-third, maybe a little better than one-third of patients have a durable response, but the rest don't have the responses we would like to see. And then I always like to show this slide, which is to me so demonstrative of our need to better understand biology, is you take 5 patients with the same exon mutation in EGFR, and they have wildly disparate outcomes with respect to PFS on first-line osimertinib. And this goes to show you that we still have to understand better the role of co-occurring mutations, the role of host biology as an integrated solution to better understand which patients will benefit the most from a systemic therapy approach in terms of durability of outcomes. And so what we did many years ago now, it's almost 11 years ago, was that we took a small study as a proof of principle, 24 patients, and we proved that these patients that had been heavily pre-treated with first line, second line, third line treatments in an era preceding both preceding immunotherapy, that these patients could, in an oligoprogressive state, could benefit from the utilization of local therapy in the form of radiation. So basically, these patients, advanced non-small cell, progress through multiple courses of systemic therapy, and then basically these patients were given radiation therapy. And what we found was that, in a single arm study, we were just looking for signal. And the signal was impressive. Not only did we have limited toxicity, but we also showed that the PFS in this patient population was 15 months. Overall survival was 20 months, which is way better than what most would have seen in this group in an era preceding immunotherapy. And our patterns of failure are exactly what we predicted in this setting of oligoprogression. Many fewer local failures and many more delayed distant failures. And that, I think, kind of led to Curb, which was just published in Lancet within the last year or 12 months, which really established in a phase 2 setting that local therapy in salvage for oligoprogressive disease for non-small cell lung cancer can really be of benefit. And this is now a cooperative group study in the United States and Canada and North America. And we hope to really get a sense of the benefits of salvage therapy, local therapy in the oligoprogressive setting for non-small cell in the not so distant future. So I come back to this slide and to really push the idea that we need to understand the biology better. We need to understand how to predict these patient populations. And I personally think it goes back to resistance studies, understanding mechanisms of resistance. And really what I think is that those patients who are and what many people think is that those patients who are progressing early are those patients that have much greater clonal heterogeneity in their tumor at the time of diagnosis. And that is why a single therapy is not likely to promote any form of durable benefit. So keep that in the back of your mind. Then we have these patients who progress maybe 4 months, 6 months, 8 months, a year, year and a half into their systemic therapy. And these, I would argue, are the non-durable responders because they start developing either an acquired resistance to the immunotherapy or an acquired resistance to their targeted therapy. And so what does this lead? I think it leads to us to better understand how to bin patients in terms of when to use local therapy as an optimization tool. And I think radiation and surgery will in the future be a succinct and clear mechanism to avoid resistance in patients, to allow them to remain on their systemic therapies, which we think, the longer they remain on their first line systemic therapy, the more options they're going to have in the future and the greater the durability of the outcome. And why are we going to switch a patient's systemic therapy when it's doing so well in 90% of the body, when a local therapy can help in the areas that are either developing resistance or already showing resistance? And so I think this is where local therapy is going to be of significant benefit. And then, to my last point of my presentation is, why not consider using local therapy just for the primary and avoiding treatment of the nodes, which we know are sites where immunotherapy is required to optimize their T cell activation. We've learned a lot from our head and neck colleagues including Dr. Chua and many others, about the need to perhaps avoid a systemic treatment, if you will, within the thorax, but to focus maybe on the primary. And having seen how well ivonescimab has done, going head to head with PD-1 inhibitors, we decided that maybe it would be relevant to do a trial with Summit, and we're actually initiating a early phase trial to make sure it's safe to deliver SBRT to the primary disease, followed by sequential treatment with ivonescimab. Once we established a safety profile, then I think we really will push to see if ivonescimab's increased ability to control systemic therapy will work in conjunction with our ability to treat the primary and reduce the likelihood that clonal heterogeneity will promote early therapeutic resistance. And so my final slide is a push for our understanding, or better understanding of biology. If we know about early failure as a function of clonal heterogeneity versus intermediate or late failures as a function of acquired resistance, we can start binning the patients into categories where we can consider when to use local therapy optimally, either upfront for the patients that have significant clonal heterogeneity, or further in the outback, or only at the time of oligoprogression on these patients who are on TKIs who are doing so well. We don't want to disrupt their treatment, but only and get involved when acquired resistance is becoming more obvious. And with that, I'll be happy to take any questions. I thank you very much.
Amazing. Thank you so much for such an amazing overview and also for your leadership in this field. I've got so many questions myself. I'm going to even give the chance for the audience to talk first. First, I'm going to say congratulations on NRG LU002, major study, absolutely phenomenal. When do you have a timeline on when you think it might be published that we can have,
Yeah,
details?
we're actually going to send it out this week. So it's a timely question you asked. We're going to send it out this week, and we hope to get some reviews back within 6 or 8 weeks, and hopefully soon after we would get it published. So it's definitely going out this week.
Many congratulations for that and best wishes for the submission. With regard to the conclusions for NRG LU002, do you think that it's much of a done deal that local consolidation actually doesn't improve some overall survival in the trial setting for the entry criteria provided?
Yeah, I mean, I think you know, in looking back, I probably think that we should have done a smaller study with immunotherapy as the systemic therapy of choice to ensure that the toxicity profile was limited. But we'd seen so many studies from different groups saying immunotherapy given sequentially with radiation is safe. But remember, I mean, our study did include all these patients that were getting 45 and 15 to large volumes of their mediastinum, and that I think that exacerbated toxicity. Clearly, the evidence suggests that, as you will see in the manuscript. So I think that I cannot argue against the evidence of LU002, but what I can say is that toxicity had a lot to do with it, and quite honestly, in a study of 218 patients, 15 or 20 patients who could have been on systemic therapy a lot longer if they did not have pneumonitis, unfortunately, could change the statistics rather significantly. So I still think that it's a chance that it'll be a real treatment. We just have to prove it in subsequent studies, unfortunately.
Definitely. I mean, this reminds me a lot of MAS2, where we tried to do a study demonstrating the effect of surgery, hopefully, expecting a positive result, and to find that it did
Yeah.
harm for MAS2 is going to be, I think, it was pretty much really hits home really hard on the importance of randomized control trials. One major subgroup that everyone's asking about is the subgroup with genomic drivers, EGFR and ALK. Do you have any insights you can give us with regards to this subgroup? Because in the earlier studies, like with what Daniel Gomez has done, he was showing that this subgroup had up to 80% reduction in the risk of death.
Yeah, I think the UK itself is one of the leaders on some of these studies with the patients with EGFR and ALK mutated disease. I think that there's a very significant chance that local therapy would be very helpful for these patients in consolidation. But I'm starting to think that when you have such amazing results with lorlatinib, you're going to start seeing that second, third, fourth generation, fifth generation ALK and EGFR TKIs are going to be so good at overcoming previous forms of resistance that why really, consider rocking the boat with local therapy and causing any toxicity that will limit these patients from receiving systemic therapy. And really for these patients, and I think curb 2 is the right curb, and the curb 2 is the right approach, really limiting the local therapy for progression, for oligoprogression. It could even be for beyond oligoprogression, because, the thing that I like to tell everybody is, a patient may have 15 Mets when when they've identified to have progression. But if we could have a model that said, if we treat those 15 Mets safely, and David Palma's data is suggesting that we may be able to treat a large number of lesions with local therapy safely, and we knew that for 3 years the patients would be disease free, we would treat those 15 lesions. But if a patient had one lesion, and we knew that even if we treated that one lesion, within 4 months they would have 15 spots, new spots, we wouldn't treat even a one lesion. So I think having greater granularity about the trajectories that I was talking about will help us select the patients better.
Yeah, definitely. That brings me to the question of, we often define oligometastatic as 5, but exactly as you said, it's more like biology driven and trajectory driven rather than actual numeric value. I mean, do you have any view on, arbitrary numbers we use? I mean, for clinical trials, I understand that, you need to have a clear entry criteria. For the Ramon clinical trial, we said if you can treat them all radically, you could then enroll them
Yes,
in the
yes.
study. But that went down very, very badly with
Yeah, no,
the
right.
recruiters.
Oh, I think we're going to see, as we've talked about, that as we get more information. Dan Gomez and has led a study that hopefully will be published soon. That before I got to MSK, and then I was lucky enough to become part of that. If you have patients with metastatic disease, large number of lesions, but they have an EGFR mutation, I think that's probably a lot better in terms of prognostic outcomes for survival than having 3 lesions with an STK11 mutation. And so, even by just adding the mutation variant status to the number of lesions, you start getting a dichotomy and a divergence in the outcomes. And so, that's why I'm saying that in the future, and as you've said as well, it's going to be number of lesions plus the mutation status plus how well did they do on first line systemic therapy that will establish how and when we should treat these patients.
Because very interestingly, next week we have Professor Elena Klenova, who's going to talk to us about the patient perspective. And from a patient's perspective, they've written some guidelines for ALK-UK with the pushing for the hypothesis that radical management for the oligometastatic disease may have potential to, prevent acquired resistance developing in the future
Yep.
if you can actually physically remove
Yeah.
them.
So
So
yeah.
that's yeah.
Oh no, I was just going to say that's absolutely 100% correct. And the key for us will be able to predict when that resistance occurs. So maybe if we collect ctDNA on patients who are on TKIs every 2 months, okay, and we start seeing a change in the variant allele frequency of certain genes, which suggest an increased clonal expansion of one population over another, we could start to predict that maybe in 4 months the resistance would manifest as macroscopic progression. So then it would be maybe at that time that we would want to treat what is visible and remaining. So I completely agree with her thoughts about that.
And can I ask, what's your view? Do you think surgery and radiotherapy are competing or complementary?
Absolutely complementary. I love working with our surgeons to figure out what is the best integrative approach. I think a solitary lesion, absolutely, why not do surgery? Whether it's the adrenal, of course, the brain, of course, lung, I think, or liver, wherever. I think, even multiple lesions that are in close proximity, you learn so much from the tissue in terms of the tumor, the genetic variations and alterations with time that I fully support an integrated response. And I think it just takes a little bit of effort, though. We have to come together, talk about the patients, but by all means, we should work together in harmony with for these patients' benefit.
Okay, I need to give the audience some some leeway as well to get to get some insights from you. One of them is from Paul Bass, who's asking about SBRT if it induces an abscopal effect in selected patients, or is it through other mechanisms?
I unfortunately think for non-small cell, I think I've treated enough patients to feel that I don't see an abscopal effect. I think that non-small cell is not as immunogenic as melanoma or renal cell, which is, the main reason why pharma went to those diseases first, because they knew they were more immunogenic, had more MDSCs, and radiation does induce some kind of abscopal findings in those types of more immunogenic tumors. In non-small cell, I don't see it as much, but it doesn't mean we can't engineer it to occur with the bispecifics or the bites or some novel approaches to induce it. But right now, naturally, it doesn't happen.
Thank you. A question from Dr. Ato Gibania, who's asking, what are the potential future strategies that we can adopt to mitigate or minimize therapeutic toxicities going forward in this setting?
Yeah, I think one of the things was what I mentioned at the end is which only treat the primary. Maybe we don't need to treat the nodes because systemic therapies are getting so good. We don't need to treat the nodes, and it's having to treat both the primary and the nodes that I think led to the increased toxicity that we saw with respect to the pneumonitis. The other thing is maybe we have a neoadjuvant approach. We of course start with induction systemic therapy, let the disease shrink, and it's going to shrink more. It's because a lot of these drugs are not just tumoristatic, they're tumoricidal. And so we may get a lot of shrinking of the disease, which allows us to treat a much smaller volume of disease. And then finally, there's all these ideas that, maybe we only need to treat certain mets that go to the liver or the adrenal, because we need to identify which deposits of disease are going to result in further metastatic dissemination. And so if we knew for a fact that the primary was at greater risk of shedding cells that were going to seed elsewhere, we could only focus on the primary. If we knew that it was a met to the liver or the adrenals, we could perhaps focus in those directions as well.
Excellent. Thank you so much, and thank you for your leadership in this area. It's been world-class excellence from the work that you've produced throughout your career, which all of us are paying close attention to. I'm going to end up with one final question. It's going to be a tricky one. All three guidelines, ASTRO, which I think you authored, ESMO, as well as ASCO guidelines, currently and surgical guidelines recommend, uh, surgery and radiotherapy as local consolidation for oligometastatic setting. Do you think the results of NRG LU002 is going to change these?
Yeah, I think it is. I mean, Astro guidelines were completed prior to the findings, and I would say that if we have to be transparent, we have to be honest with ourselves, and the highest level data in the setting of LCT says that it does not provide a benefit. So I think we do have to say at this moment in time that LCT should not be the highest. There should not be the highest level of support for LCT utilization, but we need to think about it in a patient by patient case basis. But the guidelines should follow the data. That's absolutely true.
100% agree with you. Thank you so much for your time and coming to give us your insights today. Leaves me to thank once again our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care, and especially for your leadership and your time given to us today, Puneeth. Thank you so much.
Thanks, Professor Lim. I really appreciate it.
Us too. Bye-bye.